Welcome to the deep dive. Today we're tackling tuberculosis, or TB. It's a big one, historically, globally, just really impactful. And, understanding it isn't just about facts for an exam. It's about preparing for decisions that genuinely affect people's lives. Before we jump in, though, let's just take a moment, take a deep breath in, okay, and release. Now, maybe think of one thing you've overcome recently. Could be anything, a tough study session, a tricky situation, or just, showing up today to learn this stuff. That's your strength right there. Let's hold on to that feeling as we get into TB. You've got this. And hey, if you're new here, welcome. So glad to have you. And for our subscribers, seriously, thank you. Your support really helps us grow and reach more people. If this deep dive helps you out, maybe hit like or subscribe. It helps others find us too. All right, so tuberculosis. Our mission today. To really unpack it, we need to understand the difference between latent and active TB, obviously. Then we'll dive into those key first-line drugs: Isoniazid, Rifampin, Pyrazinamide, and Ethambutol. We got to know those inside out. We'll also touch on big challenges like drug resistance, why directly observed therapy, or DOT, so vital, and of course monitoring, side effects, patient counseling, all that crucial stuff. And we can't forget the public health side either. Reporting, prevention, it's all connected. So to get us started, maybe a quick recall question, just to warm up the brain cells. Which first-line TB drug is most linked with peripheral neuropathy and needs that pyridoxine supplement?
That's going to be Isoniazid, INH.
Right.
And remembering that link, the pyridoxine, it's really fundamental for keeping patients safe and actually sticking with the treatment.
Definitely key. Okay, so let's build this up from the ground floor. What exactly is tuberculosis, and why, after all this time, is it still such a major global health issue?
Well, basically, TB is an infection. It's caused by this specific bacterium, Mycobacterium tuberculosis, which is an acid-fast bacillus, or AFB. And, a huge part of why it's such a persistent problem is how it spreads. It's airborne.
Airborne. Okay.
Yeah, person to person. Someone with active TB coughs, sneezes, even talks, and releases these tiny little droplet nuclei into the air. Someone else breathes them in, and that's how it starts.
So that immediately signals why public health is so wrapped up in controlling TB. But what happens after someone's infected? It's not always straightforward, right?
Not at all. That's a really fascinating and kind of sneaky part about TB. The vast majority of people who get infected, maybe around 90%, actually develop what we call latent TB infection, or LTBI.
Latent, meaning it's just sitting there.
Exactly. Their immune system basically walls it off. So they have the bacteria, but they're completely asymptomatic. And crucially, they're not contagious. They can't spread it.
Okay, that's a huge point. So 90% are latent, non-contagious. What about the other 10%?
So only about 10% of people infected will eventually develop active, symptomatic TB disease sometime in their life. The risk is actually highest in the first couple of years after they're initially infected.
Right. So what tips the balance? Why do some people stay latent while others progress to active disease? What are the big risk factors?
Immune status is really the main driver there. HIV infection is probably the biggest risk factor globally.
How does that work exactly?
Well, HIV attacks T lymphocytes, specifically those CD4 plus cells, which are absolutely critical for controlling TB. So when the immune system is weakened by HIV, the body just can't keep the TB bacteria in check anymore, and it reactivates.
Makes sense. Any other big ones?
Definitely. We also see a higher risk in patients taking certain medications, like TNF-alpha inhibitors. These are often used for autoimmune diseases like rheumatoid arthritis or Crohn's.
Because they suppress the immune system, too.
Precisely. They dampen the very immune response needed to keep that latent TB dormant, so reactivation becomes much more likely.
Okay, so if someone does develop active TB, what does that look like clinically? What symptoms should make us think, could this be TB?
The classic picture involves the lungs that's pulmonary TB. So you're looking for a persistent cough, often productive, meaning they're coughing up sputum, that lasts for weeks, maybe 3 weeks or more. Also things like fever, unexplained weight loss, just feeling generally unwell, and those characteristic drenching night sweats.
Night sweats, yeah, that's a classic one.
It really is. And in some cases, it can progress to hemoptysis, which is coughing up blood. That's usually a later sign.
And it's not always just the lungs, is it? I remember reading it can pop up elsewhere.
Absolutely.
Yeah.
That's extrapulmonary TB. It can affect almost any organ system. The kidneys or bladder, genitourinary, bones and joints, skeletal, the brain and spinal cord, CNS, even the lining around the heart, pericardial. And in people who are very immunocompromised, you can get disseminated TB, where it spreads throughout the body, affecting multiple organs at once. So yeah, the presentation can be really varied.
Wow, okay. That definitely makes diagnosis sound challenging, especially distinguishing latent from active. How do we actually identify TB in a patient? What are the steps?
Diagnosis is key, you're right. For initial screening, especially for latent TB, we have two main tools. First, there's the tuberculin skin test, the TST, or MEN2 test.
A little bubble under the skin.
That's the one. We inject a tiny amount of purified protein derivative, PPD, intradermally, usually on the forearm. Then, critically, we have to read it 48 to 72 hours later. And what we're measuring is the induration, the hard raised bump, not just any redness. But here's the vital part. The size of that induration that counts as positive depends entirely on the patient's individual risk factors for TB.
So it's not just one cutoff size for everyone.
Nope. For example, an induration of 5 millimeters or more is considered positive in someone who has HIV or who's been in recent close contact with an active TB case or is significantly immunosuppressed, like an organ transplant recipient, or even if they have chest x-ray findings suggesting old, healed TB.
Okay, 5 millimeter for high risk. What about others?
Then we have a 10 millimeter cutoff. That applies to people like recent immigrants from high-prevalence countries, injection drug users, residents or employees of high-risk settings. Think prisons, nursing homes, hospitals, homeless shelters, also lab personnel working with mycobacteria, and people with certain medical conditions like diabetes or chronic renal failure, and children under 5 exposed to high-risk adults.
Got it. And for the general population?
For people with no known risk factors, the cutoff is higher, 15 millimeters or more.
That tiered approach makes sense. What about the BCG vaccine? Does that interfere?
It can, yeah. The BCG vaccine, which is common in many parts of the world but not routinely used in the U.S., can cause a positive TST result. That's one reason why it complicates TST interpretation here.
Okay, so that's the TST. What's the other main screening tool?
The other option is an interferon gamma release assay, or IGRA. This is a blood test.
A blood test, right. Easier sometimes.
It can be. It measures the T-cell release of interferon gamma in response to specific TB antigens. Big advantages. It's faster, usually results in 24 hours, versus 2 to 3 days for the TST read. And crucially, it's not affected by prior BCG vaccination.
Oh, that's a significant advantage.
It is. So IGRAs are often preferred in people aged 5 or older who had BCG or maybe are at low risk, but unlikely to come back for the TST reading.
But does it tell you if the TB is active or latent?
That's the limitation. Like the TST and IGRA tells you if the person's immune system has encountered TB antigens at some point. It does not differentiate between active disease and latent infection.
Okay, so TST and IGRA point towards exposure or latent infection. How do we confirm active TB?
Right. If someone has symptoms suggestive of active TB, or maybe a positive screening test and risk factors, we need to go further. The gold standard involves getting sputum samples for acid-fast bacilli smear and culture.
Sputum culture, okay.
Yes, and alongside that, a chest radiograph or x-ray is essential. And, very importantly, we need to test the bacteria for drug susceptibility right from the start. That guides our treatment choices.
That makes sense. You need to know what you're fighting. So moving into treatment, it sounds like a long haul. What are the main goals when we treat active TB?
Yeah, treatment is definitely a commitment. The main goals are threefold. First, obviously, cure the patient and prevent death. Second, stop the transmission to others. And third, prevents development of drug resistance and relapse later on.
And the key to achieving that, especially preventing resistance, is using multiple drugs, right?
Absolutely non-negotiable. Combination therapy is the cornerstone of TB treatment. Using just one drug would rapidly lead to resistance, so we always hit it with multiple agents, especially in the beginning.
Okay, so what are the go-to regimens? What's the standard approach?
The long-standing standard, and still very common, is a 6-month regimen. You might know the mnemonic RIPE.
RIPE, yeah. Rifampin, Isoniazid.
Pyrazinamide, and Ethambutol. Exactly. So the initial phase, or intensive phase, lasts for 2 months, and the patient takes all 4 of those drugs, RIPE.
2 months of 4 drugs. Then what?
Then comes the continuation phase, which typically lasts for another 4 months, so 18 weeks. During this phase, they usually only need to continue 2 drugs, Isoniazid and Rifampin.
So 4 months of just INH and Rifampin?
Generally, yes. And that Ethambutol, the E in RIPE, if the initial drug susceptibility tests come back showing that TB strain is sensitive to both Isoniazid and Rifampin, you can often stop the Ethambutol even before the 2-month mark.
Okay. Tailoring it based on sensitivity.
Precisely. There are also variations, like intermittent dosing schedules, maybe 5 times a week instead of daily, which can sometimes help with adherence under DOT.
You mentioned DOT, directly observed therapy. Let's talk about that more later. Is there an alternative to the 6-month RIPE regimen now?
Yes, relatively recently, since about 2022, there's a newer 4-month regimen that's become a preferred option for certain patients.
4 months instead of 6, that sounds like a big improvement.
It can be. This one also starts with a 2-month initial phase, but the drugs are slightly different. It's rifapentine, moxifloxacin, isoniazid, and pyrazinamide.
Okay, rifapentine and moxifloxacin in, rifampin and ethambutol out for the start.
Right. Then the continuation phase is shorter too, just 2 more months or about 9 weeks, using rifapentine, moxifloxacin, and isoniazid.
So 4 months total. But who is this suitable for? Are there catches?
There are some important contraindications, yes. It's not recommended for children under 12 or for individuals who are pregnant or breastfeeding. Also, a big one is QT prolongation patients with a history of it, or those taking other medications known to prolong the QT interval shouldn't use this regimen because moxifloxacin carries that risk.
Okay, QT interval is key there.
And another practical point. This 4-month regimen needs to be taken with food to ensure proper absorption, especially of the rifapentine and moxifloxacin.
Got it. So whether it's 4 months or 6, that's a lot of medication for a long time. Adherence must be a massive challenge.
It's probably the biggest challenge in TB treatment. Missing doses or stopping treatment early is the main driver of treatment failure, relapse, and critically drug resistance.
Which brings us back to DOT. How exactly does that help?
The directly observed therapy, DOT, is just fundamental. It's a strategy where a healthcare worker or sometimes a trained community member physically watches the patient swallow their pills.
Every single dose.
Ideally, yes, especially for regimens that aren't daily, like 5 times a week or less often. It provides certainty that the medication is being taken. But DOT is more than just watching pills go down.
Oh, how so?
That regular contact provides a fantastic opportunity to check in with the patient, ask about side effects, monitor for any signs of toxicity, answer questions, and offer support. It improves adherence and safety. It's really a cornerstone of good TB care and public health control.
That makes a lot of sense. It's support as much as observation. Okay, what about monitoring labs during this long treatment course?
Good question. We always get baseline labs before starting any TB treatment. That includes liver function tests, LFTs like AST and ALT, bilirubin, serum creatinine to check kidney function, and a platelet count.
Baseline checks, got it. Do we need to keep checking them throughout?
Not necessarily routinely for everyone, unless those baseline labs were abnormal to begin with, or if the patient develops any symptoms that suggest toxicity, particularly liver toxicity like nausea, vomiting, abdominal pain, jaundice.
So monitor closely if there's a reason to.
Exactly. However, one thing we do often give proactively is pyridoxine, which is vitamin B6.
Right, we mentioned that with isoniazid earlier for neuropathy.
Precisely. It's strongly recommended for everyone on that newer 4-month rifapentine-containing regimen. And it's crucial for patients on any isoniazid-containing regimen who are at higher risk for peripheral neuropathy.
Who falls into that high-risk group?
That includes people who are pregnant, those who misuse alcohol, have poor nutrition, diabetes, chronic kidney failure, HIV infection, or of advanced age. Giving them pyridoxine, usually 10 to 50 milligrams daily, can prevent that really debilitating nerve damage.
Okay, super important clinical pearl there. Now let's really zoom in on these first-line workhorse drugs. Can you break down the must-knows for each one, starting with isoniazid, INH?
Sure. So isoniazid, INH. Its job is to mess with the synthesis of mycolic acids. These are unique essential fats in the mycobacterial cell wall. So no mycolic acids, weakened cell wall. It's generally bactericidal. It kills the bacteria. Big thing to watch out for. The liver. Hepatotoxicity is a major concern. It can range from just mild asymptomatic elevations in liver enzymes, which might actually resolve on their own, all the way up to severe, sometimes fatal hepatitis.
Wow, okay. Who's most at risk for liver issues with INH?
The risk goes up if they're also taking rifampin or other rifamycins. With increasing age during pregnancy and the postpartum period if they abuse alcohol, or if they already have underlying liver disease. We generally monitor LFTs monthly in these higher risk folks.
And the neuropathy.
Yep. Peripheral neuropathy is the most common neurological side effect. Tingling, numbness, burning in the hands and feet. That's exactly why we give pyridoxine B6 alongside it, especially in those risk groups. Oh, and patients should try to take INH on an empty stomach if they can tolerate it for better absorption.
Got it. Liver and nerves for INH plus B6. Okay, what about rifampin? You mentioned something unique about it earlier.
Ah, yes, rifampin. Part of the rifamycin drug class. It works differently. It inhibits an enzyme called DNA-dependent RNA polymerase in the bacteria. Basically, it stops the bacteria from making RNA, which they need to make proteins and survive, also bactericidal. The unique counseling point is the color change. Rifampin turns bodily fluids, urine, sweat, tears, saliva, a harmless but potentially alarming reddish-orange color. You absolutely have to warn patients about this so they don't panic. It can even stain soft contact lenses.
Okay, the orange alert. Clinically, what's the biggest deal with rifampin?
Interactions. Drug interactions galore. Rifampin is a potent inducer of several cytochrome P450 liver enzymes, especially CYP3A4.
Meaning it speeds up the breakdown of other drugs?
Exactly. It significantly increases the metabolism and thus reduces the effectiveness of a huge number of other medications. Think warfarin, many anticonvulsants, hormonal contraceptives, some antiretrovirals used for HIV, immunosuppressants like cyclosporine. The list is long.
So managing drug interactions is critical with rifampin.
Absolutely essential. You always need to check for interactions and potentially adjust doses of other meds or monitor them more closely. There are other rifamycins like Rifabutin, which is a less potent enzyme inducer, sometimes preferred if interactions are a major concern, like in HIV patients on complex RT regimens, and rifapentine, which is longer acting, used in that 4-month regimen.
Okay, rifampin, orange fluids, and major CYP inducer. Next up in RIPE is pyrazinamide, PZA.
Right, pyrazinamide, PZA. Its mechanism is a bit more mysterious, but we know it needs an acidic environment, like the one found inside macrophages where TB bacteria can hide. It gets converted to its active form, pyrazinoic acid there. It seems particularly good at killing those semi-dormant bacteria. It can be bacteriostatic or bactericidal depending on concentration. Like isoniazid, PZA can also cause hepatotoxicity, so liver function monitoring is important, especially if used with rifampin or in patients with pre-existing liver issues. It's contraindicated in severe liver disease.
Another liver risk. Anything else specific to PZA?
Yes. The other classic side effect is hyperuricemia, increased uric acid levels in the blood. This is quite common, often asymptomatic, but it can precipitate an acute attack of gouty arthritis in susceptible individuals.
Gout. Interesting.
Yeah. So we monitor serum uric acid levels. It's actually contraindicated if someone's having an acute gout attack. Some clinicians even use rising uric acid as a potential, though not perfect, marker for PZA adherence.
Okay, PZA, liver, and uric acid gout. That leaves ethambutol.
Last of the first line for Ethambutol, EMB. This one works by inhibiting enzymes called arabinosyl transferases, which are involved in building the mycobacterial cell wall, specifically arabinogalactan. It's bacteriostatic. It stops bacteria from multiplying rather than killing them outright. Its main role in the RIPE regimen is actually to prevent the emergence of resistance to rifampin, especially while waiting for susceptibility results.
Okay, prevents rifampin resistance. What's its main toxicity?
The big one for ethambutol is the eyes. It can cause retrobulbar neuritis, which is inflammation of the optic nerve. This typically manifests as decreased visual acuity, blurred vision, and/or changes in color vision, particularly difficulty distinguishing red from green.
Ocular toxicity, right. That sounds serious.
It can be, and it's often dose-related. Because of this risk, patients need baseline visual acuity testing and color discrimination testing before starting ethambutol. And then they need monthly monitoring of their vision while on the drug, especially if they're on higher doses, have kidney problems, as the drug is partly clear renally, or are expected to be on it for more than 2 months.
Monthly eye checks. Wow.
Yes. And it's contraindicated in patients who already have optic neuritis or in individuals who can't reliably report changes in their vision, like very young children.
That's a crucial set of monitoring points for all 4 drugs.
Okay,
let's pause for another quick recall check right here. What lab value is particularly important to monitor for a patient taking pyrazinamide?
That would be serum uric acid because of the risk of hyperuricemia and potential gout flares.
Perfect. Okay, so we've got the main drugs down. But TB care isn't just about picking the right drugs. It involves dealing with specific patient situations and thinking about the bigger public health picture. What are some key special considerations?
Absolutely. Let's start with immunocompromised patients, particularly those living with HIV. As we mentioned, they're at much higher risk for TB. Testing HIV patients for TB is critical. Treatment generally uses the same first-line agents, but sometimes the duration is extended, often to 9 months instead of 6. Also, highly intermittent regimens, like once or twice weekly, are generally not recommended in HIV co-infection.
What about interactions with HIV meds?
Huge issue. Rifampin, being such a potent inducer, can wreak havoc with many antiretroviral drugs. This This is often where Rifampin comes in as a preferred alternative rifamycin because it's a weaker inducer. Managing these interactions requires close collaboration between TB and HIV care providers.
And what's this iris thing I sometimes hear about?
Immune reconstitution inflammatory syndrome, or IRIS. This is a paradoxical worsening of TB symptoms that can happen after an HIV patient starts ART. Basically, the recovering immune system suddenly sees the TB infection more clearly and mounts a strong inflammatory response. It can be tricky to manage, sometimes requiring steroids, but it doesn't mean stopping either TB treatment or ART. The timing of starting ART during TB treatment is a careful clinical decision.
Complex interplay there. What about pregnancy and breastfeeding?
Another really important group. If a person has active TB disease during pregnancy, treatment is essential to protect both the parent and the fetus. Delaying treatment is riskier than the potential risks of the medications. The preferred first-line regimen during pregnancy is usually Isoniazid, Rifampin, and Ethambutol for the standard duration. Currently, Pyrazinamide is generally not recommended during pregnancy due to insufficient safety data, though practices can vary globally.
So RIE instead of RIP during pregnancy.
Typically, yes. And definitely avoid second-line drugs like aminoglycosides or quinolones if possible, due to known or potential fetal risks. Baseline LFTs are crucial before starting therapy in pregnant or postpartum individuals because of the increased risk of INH hepatotoxicity.
And breastfeeding.
Breastfeeding is generally considered safe and is encouraged while the parent is on first-line TB therapy. The amounts of drugs secreted in breast milk are small. However, moxifloxacin, if used, like in the 4-month regimen, though that's contraindicated in pregnancy breastfeeding anyway, should probably be avoided during breastfeeding if other options exist.
Okay, now for the really tough scenario. What happens when the first-line drugs don't work? Multi-drug-resistant TB, MDR-TB.
MDR-TB is defined as TB resistant to at least Isoniazid and Rifampin, our two most powerful first-line drugs. It's a major global health threat. Treating it is much more complex, requires longer durations, often 18-24 months or more, uses second-line drugs that are often less effective and more toxic, and needs expert consultation.
What are some of those second-line drugs?
They include fluoroquinolones, like levofloxacin or moxifloxacin, injectable agents, historically aminoglycosides like amikacin or streptomycin, though less used now due to toxicity, and other oral agents like bedaquiline, linezolid, cycloserine, ethionamide. It's a whole different arsenal. Bedaquiline, for instance, is a newer drug that works by inhibiting ATP synthase in mycobacteria. It's potent, but requires careful monitoring, especially ECGs for QT prolongation, and has significant CYP3A4 interactions.
And the key principle when dealing with resistance.
The absolute cardinal rule: never add just one single drug to a failing regimen. If you suspect treatment failure or resistance, you must add at least 2, preferably 3, new drugs that the bacteria are likely susceptible to based on testing or history. Adding just one drug breeds further resistance.
That's a critical point. So throughout all this, how do we actually track if the treatment is working? How do we measure success?
The main way is through microbiology. We monitor sputum smears in cultures. Patients with pulmonary TB should provide sputum samples regularly, maybe every 1-2 weeks initially, until their smears become negative for acid-fast bacilli. The goal is sputum culture conversion, meaning the cultures stop growing TB bacteria. This should ideally happen within the first 2 months of treatment. If a patient's cultures are still positive after 2 months, that's a warning sign.
What do you do then?
You need to reassess everything. Recheck drug susceptibility testing on the positive culture, evaluate patient adherence, is DOT needed, check for drug interactions, potentially measure serum drug levels to ensure adequate absorption, and consider consulting a TB expert.
It really underscores the need for careful follow-up and adapting the plan.
Absolutely. And it loops back to the public health strategies. TB is reportable, infection control in healthcare settings is vital, contact tracing for close contacts of active cases is necessary.
And DOT.
And DOT, yes. It's not just about individual patient adherence. It's a public health tool to ensure cure, prevent resistance spread in the community, and provide that essential patient support and monitoring link.
It all connects. Okay, one final recall question on the drugs before we wrap up. Which TB medication necessitates those monthly visual acuity tests?
That has to be Ethambutol because of the risk of optic neuritis.
Exactly. Ethambutol and eyes definitely link those together. You know, if this breakdown is making TB clear for you, maybe take just a second to hit the like button or subscribe if you haven't already. It really does help other folks find this content when they're searching for reliable info. All right, so let's try to boil this complex topic down to some essential take-home messages, some summary pearls. First, remember RIPE for that initial standard therapy. Rifampin, Isoniazid, Pyrazinamide, Ethambutol, it's your starting point. Second, Isoniazid plus pyridoxine B6 equals neuroprotection. Always think about preventing peripheral neuropathy, especially in those at-risk groups. Third, rifampin interactions galore. That potent CYP induction is a huge clinical consideration. Always check for drug interactions. And finally, maybe the broadest point, TB isn't just clinical, it's public health. Treatment, adherence, resistance, transmission, it all has community-wide implications.
That's a great summary. And maybe one final thought to leave you with. What's really quite profound is how this ancient disease, TB, continues to challenge us. Its biology is complex, it evolves resistance, it keeps us on our toes. So diving deep like this, understanding the diagnosis, the intricacies of drug therapy, the monitoring, it's not just about passing an exam. It's fundamentally about equipping yourself as a future or current healthcare professional to contribute effectively to a global fight. Every informed decision you make has ripple effects on public health. And honestly, the ongoing struggle against MDR-TB is a stark reminder that vigilance, ensuring adherence, and continuing to innovate in treatment and prevention, these are absolutely essential ongoing requirements for all of us in healthcare.
That's a powerful perspective. Thanks for diving deep into tuberculosis with us today. It's a heavy topic, no doubt, but sticking with it and really understanding it, that persistence is what makes a difference. If you found this useful, please do subscribe, like, or maybe share it with a friend or colleague who might benefit. Our goal here is always to learn deeply, support each other's growth, and help everyone show up ready for the exam, ready for patients, ready for the challenges ahead. Until next time, keep learning, stay grounded, and take care.